Okay, again we'll start from the anatomy of elbow joint. It is also just like ankle joint. It is synovial hinge joint. The primarily articulation is between the primary articulation again is between the humerus and ulna. This is primary articulation. Other one is between the humerus and radius, and third articulation will be ulna and radius, radio-ulnar joint. So these are the primary anatomy of elbow joint. Next is the ligament surrounding the elbow joint. So one is the capsular ligament, other will be the ulnar collateral ligament on the ulnar side, medial aspect. On the lateral aspect, we'll have the radial collateral ligament, and on the lateral aspect again there is a one ligament, lateral ulnar collateral ligament, which is not shown in this picture. Then again surface anatomy. On the elbow joint, usually we see this is the from the medial aspect. This is medial epicondyle. If you get tenderness on this area or just below the medial epicondyle, the possibility of Wolfer's elbow, okay, medial epicondylitis. This is the olecranon process. If you get any swelling or tenderness in this region, the possibility of olecranon bursitis, okay. If you get effusion in the olecranon, grooves are there on both the side of olecranon process, the possibility of intra-articular effusion, okay, and olecranon fossa, which is lying above the olecranon process, we can get the effusion or swelling in the intra-articular when you get a synovitis or inflammatory arthritis. So we can get swelling just above the olecranon process. On the lateral aspect, we see this is lateral epicondyle, which is the commonest tender site in the cases of like tennis elbow, commonest elbow condition we come across in our OPD. But along with the tennis elbow, we should not forget about the PIN entrapment, which is usually coinciding like or presenting similar like tennis elbow. So we should be able to differentiate between these two clinical conditions. How we can differentiate PIN or tennis elbow? Then other important structure is radial head. How to palpate for the radial head? How we can confirm whether this is radial head or lateral epicondyle? With just actually below the lateral epicondyle and do the pronation supination, okay, movement of the forearm movement. So we can just feel the movement of the radial head. So we can get the tenderness in this area when the patient gets some injury with the outstretched hand. We can get the tenderness in this area if there is a lateral collateral ulnar ligament injury or fibular head, a radial head fracture. So we can get tenderness in this region. Then like ankle joint examination, the elbow joint examination also comprises of inspection, palpation, range of motion, power assessment and some special test. It is actually a good practice. Always do the examination of hand and forearm. When you are examining the elbow joint, don't forget about the hand and forearm, because in some of entrapment neuropathy, like ulnar entrapment neuropathy or median entrapment neuropathy, we can get the wasting of hand muscles, even in the forearm muscles, okay. Forearm muscle when there is a pronator teres syndrome, okay, and if there is a entrapment of the median nerve, we can get the forearm muscle wasting. So make a good practice of examining the forearm and hand muscles. In the examination of elbow joint, usually we see for the attitude, means positioning of the elbow joint, then alignment. In alignment, usually we see the carrying angle, then deformity, different types of deformities swelling of the elbow joint, muscle bulk just above the elbow joint, below the elbow joint, and hand also, and different types of scars and sinuses, whether there is any surgical scar or sinuses in the chronic condition like osteomyelitis of joint or any bone, we can get a sinuses. The attitude you can see in this picture. In the first picture, this is the normal attitude. The elbow, shoulder basically facing in the front side, forearm, okay. Just keep your hand, ask the patient to keep your hand like this with the supinated position, and you can see it is almost like straight or little bit of valgus in position. As compared to this normal, you can see there is a internal rotation of shoulder, okay, internal rotation of upper arm and pronation of forearm, extension of elbow and flexion of. Just make a practice how to basically describe the hand in the clinical examination. Many a time you get basically small cases in your exam. So how to describe this type of attitude. Then alignment. So this is the inspection part. Just make an imaginary line from the center of arm and from the center of forearm. The intersecting point will be carrying angle. The carrying angle in the male usually it is 5 to 10 degree normal, and in the female it is usually more as compared to the male. It is 10 to 15 degree. Can any one of you tell me what is the importance of carrying angle? Why the God has given some sort of deviation from the normal alignment? So to avoid basically hitting of the upper limb to the pelvis. So female has a wider angle. Again the carrying will be easier. Suppose we carry the things in our hand, so it will be easier. Then you can see the deformities like this is cubitus varus, when the elbow and forearm is internally basically deviated internally from the midline. So this type of cubitus varus deformity is common in the supracondylar fracture or medial epicondyle fracture. So medial, the part which is fracture, it will have a lesser growth as compared to the normal side. Okay. Cubitus varus deformity also called as a gunstock deformity, and this is cubitus valgus deformity. It is externally rotated, and it is common in the lateral epicondylar fracture. Then swelling around the elbow joint. To observe for the swelling, just look from the front, back, medial and lateral side. Now this is the posterior aspect. When we get a swelling over the olecranon process, the possibility of bursitis or student elbow, abnormal prominences is seen. Sometimes if there is a olecranon subluxation, it may be happened because of some trauma, or even in the severe cases of inflammatory arthritis, we may get the subluxation of olecranon process. In the para-olecranon groove, which is just beside of olecranon process, you just look for the whether there is any fullness, so which may be coming from the intra-articular joint effusion or synovitis. In the frontal aspect, we can see the Popeio sign. What is Popeio sign? In biceps tear. It may be seen in the heavy weight lifter. Okay. Myositis ossificans, which is common in the many of the spinal cord injury patients, stroke patients. Okay, and we are used to examine the myositis ossificans also. Laterally, there may be the possibility of if you get the lateral swelling, the possibility of radial head dislocation. Again, the history is very important, whether the patient had any sports injury or road traffic accident, something. So we need to ask the patient about the history also. Then look for the muscle bulk. Start from the biceps, okay, and the forearm muscle wasting. In the cases of entrapment neuropathy, even in the frozen shoulder, when the patient is not using his arm, we can get the disuse atrophy also. Then scar and sinuses. On the palpation, again look for the temperature, compare with the normal side, tenderness as per surface anatomy, and while palpating, start with the bone. You can start with the from distal to proximal, proximal to distal, medial, lateral, and make a habit of palpating in each section of particular joint. The palpation of tendon, muscles, and nerve. Don't forget about the nerve. Like around the elbow joint, there are the three different nerves. One is the ulnar nerve, which is commonly maybe involved around the elbow joint. We can get a snapping of ulnar nerve. Okay, snapping of again triceps also. These two conditions may be coincide with each other, or we can get confused easily with the snapping of ulnar nerve or snapping of triceps tendon. Then anteriorly, you need to look for the biceps tendon and laceratus fibrosus, because these two sites are very important when we are thinking of the median nerve entrapment. There are the three different sites of median nerve entrapment. Can you tell me about median nerve entrapment? Where easily we can get the median nerve entrapment in the elbow and forearm? One is the carpal tunnel, commonest, coronary teres. Then this area, laceratus fibrosus, we can get the impingement. Other one is a abdius arch, basically, flexor digitorum superficialis arch. So I will describe how to basically identify the impingement of the median nerve at these three sites. Then palpate for the muscles, bicep muscle, brachioradialis muscle, brachial artery, which is again medial to the biceps tendon, and median nerve, which is medial to the artery. We can get the biceps tendon and laceratus fibrosus tenderness when you are expecting of like biceps tendinitis. In the weightlifter patient, suppose there is a tear in the biceps tendon. In that cases, you will not able to find out the tendon because it is deeper. Even with the ultrasound also, it is difficult to make orient with the biceps tendon. And posteriorly, we look for the olecranon process, olecranon, bursa, groove, triceps tendon. We can get the tenderness at the just over the olecranon process or above the olecranon process. So, and again doing the resistance testing for the tendon, we can get idea about the insertional tendinitis. Make a habit of palpating the bony structures also, like ulna, if it is tenderness, and the history of fall, the possibility of nightstick, fracture of ulna, and posterior interosseous nerve. The pain will be present in the radial tunnel syndrome, just below the radial head. Okay. There are the two different terms. One is the radial tunnel syndrome and other one is a PIN, posterior interosseous nerve entrapment. Some actually people use this term as a same. Some says it is in the radial tunnel syndrome, it is more of sensory symptoms, and in the PIN it is more of basically more of motor symptoms. In the lateral aspect, just palpate for the radial head and capitulum. That if you are feeling, suppose the patient is feeling of tenderness over the radial head, the possibility of radial head fracture, tenderness over the capitulum in the athlete, suggestive of the Pannus disease. In the lateral epicondyle, you can look for the lateral epicondylitis and also make the habit of palpating the supracondylar ridge also. Okay, supracondylar ridge tenderness we can expect in the cases of like supracondylar fracture. On the medial side, the common pathologies like Wolfer's elbow, medial epicondyle fracture. So palpate on the medial epicondyle, then medial epicondyle ridge, and for the ulnar nerve, just palpate in the cuboidal tunnel. And for Tinel sign, you can do the Tinel sign examination and look for the just while palpation, look for the whether there is subluxation of ulnar nerve or not. We can get in the ulnar nerve instability. This bony relation is very important, and while doing the clinical examination, make habit of marking the different different, these are the bony landmarks. This is lateral epicondyle, medial epicondyle and olecranon process. Ask the patient in the 90-degree, flexion of elbow in the 90-degree. So you will get the isosceles. Okay, it is triangular structure. And when the patient is trying to extend, so all the bony landmark will come in the straight line. What is the importance of uterus triangle? If there is any history of fracture, okay, in any of the structure, if the fracture in the medial epicondyle, lateral epicondyle or olecranon, so this line will be disturbed. So we can't make basically this straight line. So you can get a fair idea about whether there was a recent history of fracture or past history of any fracture. Then common measurements in the carrying angle, already I covered it. Then 3 bony relationship, uterus triangle. Always try to measure arm length, girth, forearm length and girth. It can give the idea about the wasting of the muscle or not. Again, whether there is a shortening of the upper limb or not, and range of motion. The common range of motion in the elbow joint is extension. Usually it is 0 degree of extension, but up to 10 degree of hyperextension, it is normal. Sometimes some patient have the hyperlaxity of joint because of laxity of ligaments. So up to 10 degree we can consider it is normal. In the flexion, normal flexion is 0 to 140 degree. Pronation usually in the 80 to 90 degree. While doing the measurement of pronation, just block this joint, elbow joint, okay, by the side wall, basically block and do the pronation supination. Supination is also 80 to 90 degree. What is the functional range of motion, which is important? The functional range of motion, it is 30 to 130 degree of flexion and 50 degree of pronation and supination in each direction. So 30 to 130 of flexion and 50 degree of pronation and supination, which you usually require for to carrying out the day-to-day activities. The common pathologies around the elbow joint. Commonest, most of us know the tennis elbow, then golfer's elbow, radial tunnel syndrome, posterior intraosseous neuropathy, then Pannus disease, radial head fracture, cubital tunnel syndrome, pronator syndrome, then anterior intraosseous neuropathy, ulnar collateral ligament injuries or ulnar collateral ligament syndrome, olecranon bursitis or student's elbow, then triceps tendinitis, snapping ulnar nerve and snapping triceps. So these are the common pathologies which are usually, again, you have to decide as per the surface anatomy and patient's complaint. In the tennis elbow, usually we get the pain over the lateral epicondyle. Okay. Wrist extension weakness may be due to pain and extension more of central. As I told that there are the 2 different pathologies which usually when the patient come to us with the pain on the lateral side, usually we think of the tennis elbow or lateral epicondylitis. It is not basically initial cases, it may be the inflammatory, but on the chronic cases, the better term is lateral epicondylosis. Okay, it is degenerative condition. How to differentiate between the tennis elbow and PIN? First is the site of tenderness basically. In the tennis elbow, tenderness will be more on epicondyle, lateral epicondyle. In the PIN, the tenderness will be 2 to 4 centimeter basically, almost 4 centimeter distal to the lateral epicondyle. Okay. The night pain will be more in the cases of PIN. Okay. And again the PIN, the posterior interosseous nerve supplies the which muscle basically? Extensor compartment. Okay. Extensor carpi ulnaris. So deviation will be more of radially deviated in the PIN. And in the tennis elbow, when you examining the patient or the clinical examination, when you do the Cozen test, the deviation usually will more of central. And again, muscle weakness will be more in the PIN. There will not be any muscle weakness, maybe due to the pain. The patient will afraid of doing the extension of the wrist. These are the common tests. Basically, one is the Cozen test. Okay. In the Cozen test, we can do into the sitting position. You can see there is little bit of flexion in the elbow joint. Then maximal pronation of forearm. Okay. And make a fist and try to, and again this deviate your wrist, radial deviation. Okay. And ask the patient to make a extension and you apply the force. If the pain in the elicited into the lateral epicondyle, the possibility of lateral epicondylitis. Next test is the Mills test. These are the different tests like Cozen test, Mills test. In the Mills test, you can again done with the standing or sitting position. Same, start with the elbow flexion, forearm pronation, then flexion of the wrist, and they try to extend along with the flexion of the wrist joint. So, and put one of your thumb on the lateral epicondyle to look for the tenderness also. Okay, just start from this position and do the extension along with this flexion. So, patient can get a maximal stretching of this extensor. Then next is a modulus test. Some says actually this is the specific test for the ECRB, extensor carpi radialis brevis, which is the commonest tendon involvement in the tennis elbow, ECRB. Again, you can confirm with the ultrasound whether it is really involved or not. So, here just do the registered in the same position, again extension of the elbow, pronation, and do the registered extension of middle finger. Okay, if there is any tenderness in this area, we can just think of lateral epicondylosis. This is the golfer's elbow, same on the medial aspect of elbow joint. So, there is a golfer's elbow test, registered force to wrist flexion. Just ask the patient to the wrist flexion and you apply the registered force, and positive test tenderness over the medial epicondyle. Then cubital tunnel syndrome. Okay, what is cubital tunnel? Which nerve usually get involved in the cubital tunnel? Ulnar nerve. So, it is basically ulnar nerve entrapment. It may be due to some accessory muscles, okay, some accessory anconeus muscle, or inflammation of ulnar nerve. So, how to basically, how the patient will present of cubital tunnel syndrome? Maybe pain, paresthesia, okay, in the ulnar nerve territory. So, we can do the tunnel sign, just do the tapping in the ulnar nerve area or cubital tunnel. Then elbow flexion test, do the maximal flexion of elbow and keep the elbow joint at least for 1 minute and look for the any provocation of pain or provocation of symptoms, pain, paresthesia or tingling, numbness in these two fingers. This is half and this is full. Then ulnar stretch test. It is again the extension of ulnar flexion test. You do the flexion and do the stretching. So, ulnar nerve will get maximally stretched. Ulnar nerve compression test. Same. Again, you can just do the application of sustained, apply the force in the cubital tunnel. You can have the regeneration of pain again. For the elbow joint stability test, so we do the valgus stress test, varus stress test, or anteroposterior stability. For the valgus and varus test, don't perform the test in the elbow extension. Okay, just make little bit of flexion, okay, to unlock the joint and then apply the force. For the varus stress test, and just here you can. First, you actually stabilize the humerus, okay, and then apply the outward force, okay. Keep one of your finger over the middle aspect, ulnar collateral ligament, to look for whether there is any more hypermobility or if there is any joint opening on the middle aspect. And exactly opposite of that, you can apply the force internally, okay. For the varus stress test, look for the opening or any pain, and this test we usually do for the radial collateral ligament. This is for the ulnar collateral ligament. Another test is there, basically for the this is pivot shift apprehension test, pivot shift or apprehension test, which is for the lateral ulnar collateral ligament injury. Usually this, again, it is on the lateral aspect of the elbow, and it usually injured some sort of accident on the outstretched hand, and the patient is having like pain across, means on the lateral aspect of elbow joint, some sort of popping or clicking, especially getting up from the chair. Again, this we can use for the examination also, chair rise test, okay. And if there is a more grading of injury, ligament injury, obviously there will be the posterior lateral instability of the elbow joint. We may get basically subluxation of radial head, okay. You may get some swelling on the lateral aspect in the lateral ulnar collateral ligament injury. So there are the 3 different tests which we can easily do in the OPD setting. One is the pivot shift or apprehension test. Second is the chair rise test, tabletop relocation test. In the pivot shift test or apprehension test, we can do it in the supine position. Start from the elbow in the shoulder in the 90 degree, elbow in the 90 degree, okay. Then do the overhead actually flexion. Then start doing, basically here you have to apply 2 forces, okay. First make the extension of elbow, then pronation of the supination of the forearm with rotating the forearm with the wrist, and then start doing the flexion, okay. First you extend, then maximally rotate and then flex, because the more force will be applied, you have to apply 2 forces. One is the axial loading of forearm and valgus force at the elbow joint. At this level valgus force and at this level axial loading. So patient may get tenderness this region, this area, or maybe subluxation of radial head, okay. So this test is usually done for the if the patient is having the history and is getting the pain on lateral aspect or some sort of subluxation, clicking, so we can get this test. And I already actually discussed about the PIN. In PIN we can look for the, because this condition is nearly just like correlating with the tennis elbow. So we need to basically think of when the patient is coming on the lateral pain on elbow aspect, pain distal to the lateral epicondyle, pain and discomfort more in the night, weakness of finger extensor and extensor carpi ulnaris, and because of this extensor carpi ulnaris, the wrist will be deviate more toward the radial side and wasting of the extensor. The common test actually we use for the PIN entrapment is registered supination in the extension, because this nerve is basically entrapped into the arcade of Frosch, okay, or between the 2 heads of supinator. So to increase the entrapment of this PIN nerve, we need to activate the supinator. So just ask the patient, okay, to make in the elbow extension, okay, forearm supination, and ask him to do this supination, and you apply the opposite direction force. Again, registered middle finger extension test and rule of 9 test. This is basically rule of 9 test is the, will show this over the proximal 1/3 of forearm, just make a 9 areas. These are basically as per the, suppose the few patient, if is the sports person, he will have the broader upper arm. So this lateral, basically, the lateral area is for the PIN nerve. Okay, 1 and 2 for the posterior interosseous nerve or radial tunnel. Third will act as if you get tenderness in this area, if you get tenderness in the middle of the forearm, 4, 5, 6, the possibility of median nerve entrapment or median nerve involvement is there. 7, 8, 9 is medial aspect. This will act as a control. Okay, means you have to look for the tenderness in this 1, 2, 4, 5, 6, 2 different nerves. One is the PIN, posterior interosseous nerve, and second is the median nerve. Again is the anterior interosseous nerve entrapment. It is again purely motor nerve. So you will not get any sort of sensory symptoms because of it is motor nerve. So again this basically AIN entrapment nerve, the patient will get pain in the forearm, and look for the flexor pollicis longus, first to FDS and pronator quadratus muscle. Okay, and to check for the this FPL, FDS and pronator quadratus weakness, just ask the patient to make OK sign, just like this. Okay, and you can find out the contact between the two finger. This is thumb and index finger is just on the tip. When there is weakness of FPL or FDP, the contact will increase like a playboy sign. Okay, so you can suspect of some sort of AIN entrapment. For testing of pronator quadratus muscle, how will check for the pronator quadratus power, muscle power? Not like this, because there is a pronator teres which is measure pronation. Just this is for the pronator, it is not for pronator quadratus. When you want to check for the pronator quadratus power, just do the maximum flexion of elbow joint. Maximum flexion of elbow joint and try to pronate, and you apply to the, ask the patient to make a pronation and you apply the opposite direction force. So for checking the pronator quadratus, make the elbow, maximum elbow flexion. For the pronator teres, you make a extension, can check in the extension. This is pronator teres syndrome. This is usually confusing with the carpal tunnel syndrome. Usually when we get a patient of numbness, tingling in the hand, okay, these fingers, these 3.5 finger, we directly think of carpal tunnel syndrome, carpal tunnel, carpal tunnel, carpal tunnel. But again, you can apply your clinical knowledge. Okay. So as I told, there is a different, this is bicipital epinuresis. These are the basically entrapment sites, 2 heads of pronator and FDS superficial arch. To look for the entrapment at the bicipital epinuresis, ask the patient to make a flexion and you apply the opposite direction force. If there is a provocation of same symptoms, okay, pain, tingling, numbness, okay, so you can think of the impingement at the bicipital epinuresis. 2 heads of pronator, okay, straight, extension, do the registered pronation, okay, symptoms are generating, then think of the entrapment at the pronator side. For the FDS, again, for FDS just middle finger and do the flexion, FDS basically. Thank you. But again, there are the few points how we can differentiate CTS and pronator teres. You can get night symptoms will be more in the carpal tunnel. Night symptoms will be less in the again in the pronator teres syndrome. And in the pronator teres syndrome, we can get this sensory loss in the thumb area, thinner area. In the CTS, usually this area will be normal. The sensory loss will be in this area. this area will be normal, because the palmar cutaneous nerve which supply this area, which is coming above the carpal tunnel. Okay, so it may get involved into pronator teres syndrome. So just be aware of while doing examination. When you are examining the patient for carpal tunnel, think of pronator teres syndrome also. When you are examining the patient for the lateral epicondylitis, think of PIN entrapment also. Thank you.